Okay, good morning, everyone. Sorry for the difficulty. We've just had a bit of technical issues. This morning, it's not a very long presentation, but I just wanted to review sarcoidosis in ENT. I'm Dr. Brownell at the University of Cape Town. I saw a patient earlier this week that had confirmed sarcoid, and I thought it might be useful just to go over the kind of critical points for sarcoidosis from an ENT perspective. So sarcoidosis is, in essence, a systemic, multi-system, non-caseating granulomatous conditions. But the granulomatous condition, the non-caseating component, is not only exclusive to sarcoid. It can affect any part of the body, not only the ENT systems, but it can also occur as an isolated ENT condition. A lot of the patients that you see will actually have systemic disease, so an ENT manifestation will not be the only way in which it manifests. And the most frequently involved sites are lungs and intrathoracic lymph nodes, with more than 90% of cases of sarcoid involving these two sites. The etiology is really not well known. They think that there may be an immunological antigen, which could be viral, environmental, infectious. This then triggers a response in genetically susceptible patients. Although we don't know much about the etiology, we certainly know that in terms of granulomatous conditions, with regard to that, we actually have grown quite a lot over the last couple of years, and we actually do know a lot more about granulomatous type conditions, even though we don't completely understand sarcoid etiology. In sarcoidosis, you in essence have an activation of your macrophages and T cell activation. This results in tumor necrosis factor release and granuloma formation. So as illustrated in the histology, a granuloma is really it's a collection of macrophages that fuse to form these multi-nucleated giant cells. As we mentioned, they're not exclusive to sarcoidosis and sinonasal disease, and these granulomas can occur in many other diseases, infective, neoplastic, inflammatory conditions, and even some of our vasculitic diseases. So as such, if you have a histology that suggests that there is a granulomatous condition, you still have to maintain quite a high index of suspicion in order to actually be able to make a diagnosis. This table has been taken from Scott Brown, 8th edition, and in essence, I thought it really breaks down the other granulomatous conditions that can affect your nose and sinuses. So it breaks it down into bacterial and fungal, infective, inflammatory, and neoplastic. And under inflammatory, there we have sarcoid, which you can see. We've also got GPA, got Church-Strauss, and as well as others. Commonly in South Africa, you can see tuberculosis can also give you a granulomatous condition, as well as leprosy, which we rarely see now, although some studies show that there may be a surge in certain areas of the world. And then also in our context, syphilis can also give you granulomatous conditions. So in terms of incidence, sarcoid globally affects about 16% per 100, 16 to 16 per 1,000 population per annum. And there's quite a big geographical variation. They also think that these numbers may be influenced by the bias of reporting by healthcare workers that work within specific disciplines, for example, pulmonology versus ENT. There is a geographical variation. We know that it's about 10 to 20 times more common in African American patients and Scandinavians versus Caucasian patients. It can occur occurs in young adults, around your third to your fourth decade, and there's a slight favoring of women presenting with sarcoid versus men. Clinically, as we said, it can really affect any organ of the body. So sometimes from an ENT perspective, I think we have to bear the other organ systems in mind when we're seeing patients. And one of the kind of systems that are easy to examine and easy to see are skin lesions. Although sarcoid does primarily affect your lower respiratory tract, can also affect your upper respiratory tract, and other organs, as demonstrated in some of these images, are organs like your skin. There's an image there where they show a lupus perineo. That's the sort of reddening of the tip of the nose, which is almost pathognomonic for sarcoid. It can affect your eyes, giving you uveitis. Neurological involvement can be reported. That can either result in pain or loss of smell or neurosarcoid. Can involve your joints. And if you can see in that image, that's the clinical image of a toe that's been involved. And if you look at the radiological image, you can see there's sort of almost looking like a bit of a widening of that bone and almost like an osteolytic process. Can have cardiac involvement. From an upper respiratory tract infection and sort of mid respiratory tract, your tracheal involvement is actually rare, but your bronchial involvement is common. And often, because it largely affects your lungs, you can have chronic progressive pulmonary fibrosis in about a quarter of patients that are diagnosed with chronic pulmonary sarcoid. Other images that I thought were worth noting is the image of the patient's legs. You can see a right leg there. That's actually a nodosa. And when patients present with sarcoid, they can sometimes have a history of having these sort of reddish lesions on the anterior aspect of their tibias. And that's generally actually it can be a self-limiting form of sarcoid that sort of presents and goes rather than developing a more chronic course. So if we look at the frequency presentation of clinical involvement of extrapulmonary organs, you can see peripheral nodes is really high percentage, around 73% can be involved. Skin is quite a good clue if you're evaluating the patient clinically. A liver may be a little bit less easy for us to examine. The eye, certainly easy for us to examine in our outpatient. And then you can see all the way down towards the lower end of the table areas that involve our team, nose and mouth and lacrimal glands. And I guess the take-home message is you have to kind of have a high index of suspicion. And when you're asking history on patients where you suspect sarcoid, you've got to really ask and dig in about other organ systems that may or may not be involved. A patient may not feel that the other organ systems are related to their primary complaint, which may be sort of nasal obstruction, and they may not feel that other lesions on their leg, for example, is actually relevant. So it's important to dig in and actually ask about that. Okay. When we look at ENT clinical manifestations, the upper respiratory tract involved in around 18% of sarcoid patients, with sinonasal about 1 to 4%. If you have sinonasal sarcoidosis, it generally indicates that you've actually got more of a chronic multi-system sarcoid, although it can occur in isolation. Sinonasally, your patient may present to you with crusts and a history of epistaxis, nasal obstruction, hyposmia. The hyposmia could either be as a result of the crust accumulation within the nasal cavity or even involvement of the actual olfactory nerve. They can present you with facial pain that's generally related to a trigeminal nerve sort of involvement or distribution. They describe this kind of granular mucosa, which some of the literature describes as a strawberry skin. So you can see there's an image there. It's the best image I could find of that mucosa, which I guess looks a little bit like you imagine a strawberry with some kind of dimples in it. They also describe apple jelly mucosa, which is the image in the right, sort of more of a gelatinous looking lesion within the sinonasal cavity. In general, the mucosa is quite angry. It's quite friable. You can have some ulcerations. It might bleed. If it's very chronic, you can have adhesions developing. And then any patient with a septal perforation, particularly involving your anterior aspect of your septum, you should have a relatively high index of suspicion that this might be sarcoid. You definitely want to exclude all granulomatous conditions, but you have to have sarcoid on your radar. And some of these patients may even have had trauma secondary to surgery before, so they may have gone in for septoplasty, and the sarcoidosis in the sinonasal cavity was actually missed, and it results in failure or complication of your septoplasty in the form of a septal perforation. You can have nasal bony involvement. You can have some nasal bridge expansion, even a soft tissue mass. And as we showed in the image before, you can have cutaneous lupus perineo, which is quite obvious to see, and is actually quite a nice clinical sign to use. In the patient that we saw earlier this week, our patient actually didn't have any discernible septum at all, and quite significant nasal crusting in the nasal passage. If we look at the percentage of symptoms that patients presented with at the top, they complain of nasal obstruction, and then less so when you look in the nose, you'll see some crusting, a bloody stained nasal discharge, and a purulent discharge are almost equivocal, and some facial pain. Okay. Lawson et al. Classified the sinonasal sarcoid into sort of 4 groups. They said you can divide it into either an atrophic form or a hypertrophic form. Hypertrophic involving predominantly your inferior turbinates. You can actually have very large angry-looking inferior turbinates that are unresponsive to your regular allergic rhinitis treatment. You can have destructive lesion, would be one of the other 4 groups, and it can also be associated with nasal enlargement. So those were sort of 4 groups that Lawson et al. Classified sinonasal sarcoid into. There is a staging for sinonasal sarcoid, which is different from the pulmonary staging, and it's actually quite simple. It's only 3 stages. In your first stage, this is sort of your reversible sarcoid with only nose involvement. Your stage 2 is kind of potentially reversible, and there you've got a bit more sinus involvement. And your stage 3 is really extensive sinonasal disease, and these patients are often irreversible, and you classify that as being severe sinonasal sarcoid. When we look at a bit of laryngeal sarcoid, by far the most common site of laryngeal sarcoid is your supraglottis, around 85%, primarily your epiglottis, and then that's followed by your arytenoids. Your patient in this group could develop sort of the symptoms of a cough, even hoarseness or dysphagia. They very rarely actually present with stridor, although there are a couple of case series on pediatric patients that did present with stridor, life-threatening stridor. Scott Brown describes that you can have vocal cord deposits, but other literature actually says that it does not affect your vocal cords. So I think to bear in mind, if you're seeing a patient that looks a bit like a supraglottitis, to have on your radar that maybe this is actually a granulomatous condition. Perspective is hoarseness. At least 3/4 of patients with laryngeal sarcoid will have hoarseness of some sort. And certainly in our patient from this week, she had hoarseness for about 10 years, on and off, and had been treated with anti-reflux medication and a wide variety of other sort of scopes, everything from scopes. But in essence, we think that it's just relapses of her sarcoid. You can present with inspiratory dyspnea and dysphagia. And then other areas that are relevant to us are salivary gland sarcoid. And here we're talking about Hereford syndrome, which is when you have salivary gland enlargement, uveitis involving the eye, and even a facial palsy. So the images on the right are just different images of what a sarcoid larynx may present like. I find it sometimes easier to just look at images because this is what we do all the time. We scope patients. And if you see any of these, then although they could present as other pathology, it just has to kind of prick your alarm bells. So how do we make the diagnosis? There's no pathognomic test for sarcoid. It's really a combination of your clinical picture, a combination of imaging. If you are able to obtain histology, you would primarily be looking for non-case-setting granulomas, although that's not exclusive to sarcoid, as we mentioned. You might have some biochemical or serological testing, and really you have to try and exclude other granulomatous diseases like GPA and to mention a few others. But the diagnosis really relies on 3 major criteria. So your clinical picture has got to be compatible with sarcoid and or radiological evidence of sarcoid. Histologically, non-necrotizing granulomatous inflammation, and then you've got to exclude other causes. So again, diagnosis, you want to make sure you don't call it something else, but you need clinical, radiological, and a combination of histological confirmation. There are some clinical features that are highly suggestive, and in these cases, you may not need histology if the rest of the clinical picture fits and some of your other biochemical markers are kind of in keeping. And those clinical features which are highly suggestive are Hereford syndrome, which we've mentioned before, lupus perineo, which I've showed you a picture of before, and Lofgren syndrome, which can also present with nodosa, as illustrated by the image of the patient with the legs that I showed in one of the previous slides. So what is the role as an ENT of biopsy from our perspective? And really, if we're going to biopsy, you've got to target potentially affected tissue. So, you may refer this patient to a pulmonologist for a lung biopsy. If you see a skin lesion, dermatology might be able to help, or if you find lymph nodes that you can sample. A lip biopsy of minor salivary glands may be helpful. But if you're going to scope these patients, and you sometimes we get a referral from other teams to look in the nose to exclude sinonasal disease. If your mucosa appears normal, you're not going to biopsy that. So you'll biopsy nasal mucosa only if it actually clinically looks abnormal. There are some blood tests in urine that you can request, specifically serum angiotensin converting enzyme. Now, this enzyme's actually only elevated in about 85% of active disease. So your ACE is not going to be positive in patients that don't have active disease. And it could also be non-specifically elevated. So there's lots of other conditions that can raise your ACE, not only sarcoid. Your serum calcium or urine calcium could be elevated in around 15% of cases, so maybe a bit less helpful. But I guess when we're putting a lot of information together to make one diagnosis, it's a simple urine calcium is a relatively simple test to do. It might just add to your evidence to make the diagnosis. When we look at imaging, as we mentioned before, you can get really variable degrees of lower respiratory tract involvement. If you did a chest X-ray, you may see perihilar lymphadenopathy or infiltrates, and this makes it a bit tricky because in our context where we have a lot of pulmonary TB, to try and distinguish that from sarcoid is not easy. As I mentioned, there's the disease staging for pulmonary sarcoid, which is different from the sinonasal. In essence, pulmonary sarcoid stage 1 is your bilateral hilar lymphadenopathy, which I think we see quite a lot of on X-rays actually. Your stage 2 is when it includes pulmonary infiltrates. Stage 3 is when it starts leaning more towards kind of more chronic disease. So only pulmonary infiltrates. In stage 4 is when it starts developing pulmonary fibrosis. And in our sarcoid patient that we saw this week, she had a relatively recent CT scan which started showing evidence of fibrosis. So on your CT chest, you might see the fibrosis, you might see lung nodules. And if you do see lung nodules, this is where a bronchoscopy and biopsy may be helpful, and you may even consider requesting an EBUS from our pulmonology colleagues. These are 4 images of various chest X-rays of sarcoid patients. So in our first stage, it's a normal chest X-ray, which this hasn't shown. Stage 1 there, you can see the bilateral hilar lymphadenopathy. And I mean, if I think back to all our TB patients, they all look pretty similar. Stage 2 is sort of bilateral hilar lymphadenopathy as demonstrated by the white arrows and some pulmonary infiltrates. And then you can have a lot more pulmonary infiltrates as indicated by the white arrowhead without any hilar lymphadenopathy. That would be a stage 3. And then finally, that's advanced disease with pulmonary fibrosis. If you were going to do a CT paranasal sinus, the literature says characteristically you have soft tissue nodules in the septum or the turbinates. I must admit I've never seen this, but we don't see a lot of sarcoid in our clinic from what I've just seen anecdotally. But the problem with CT paranasal sinus is that your imaging features can be very similar to other granulomatous disorders. So you shouldn't think that by doing a CT you can make a diagnosis. It may just build on evidence. And also, if you do a CT, you can't distinguish between active disease or just a secondary infection. You might see some soft tissue changes, and you can sometimes see osteolytic changes. As you can see in that snapshot of a CT image, there's some osteolytic changes and bony changes. Okay, so how are we going to treat this? So sarcoid generally has a variable clinical course, but there's usually 2 main sort of avenues which sarcoid goes down. And the first is you can either have an acute onset, which usually they have joint pain and they have erythema nodosum, and that's often a self-limiting phase. and they can actually self-remit within about a year to two, okay? And then you can have the more chronic insidious onset, which is more commonly what we will see with sinonasal sarcoid. And in this population group, you may see lupus purina, as we mentioned before, but you also may not. About 2/3 of sarcoid patients with early pulmonary disease can actually remit spontaneously. And then that leaves around 30% that develop a more chronic course with multiple relapses, even despite giving them systemic therapy. So in essence, some of our sarcoid patients will need no treatment at all. However, some can present with a functional threat, like a posterior uveitis with vision threatening, organ involvement, and others can have life-threatening disease, although this is the minority of patients. But life-threatening disease from an airway perspective, an upper airway perspective. But we have to bear in mind that pulmonary fibrosis, pulmonary hypertension is also in essence life-threatening. So we should be referring these patients appropriately to other multidisciplinary team members. The international guidelines recommend for life-threatening disease, particularly examples like laryngeal disease, that you should give them systemic steroids. This obviously has to be carefully monitored if you have a diabetic patient, and also actively looking out for long-term side effects of steroids. If it's life-threatening, as in laryngeal disease, you can consider doing intralesional steroid injections if your systemic steroid fails. And transoral laser is also described in the literature. Steroids really are the mainstay of severe disease. There are other agents like methotrexate, which can be used as a steroid-sparing agent. And there's also a couple of case studies where some pediatric patients have actually responded very well to TNF-alpha inhibitors. For the patient that comes in with nasal symptoms, you want to try and treat their symptoms as well. So for them, you'll put them on intranasal corticosteroids. You'll instruct them to nasal douche for crusting, and you want to lubricate that nasal cavity, so you want to give glycerine drops. We've also started using some KY jelly, and and that does definitely seem to help in terms of crusting and bleeding symptoms. Septal surgery should really be avoided. There is definitely an increased risk of septal perforation, particularly in active disease. That anterior septum is particularly the area that's very prone. And a note that, if you fail to recognize that actually your patient has sarcoid in a patient who's taken to theatre for septoplasty, you can have a really bad deformity. You can actually have a subtle nose deformity. And it's important to really counsel these patients, or actually any patient that's going for septoplasty, to also be active in having a look to make sure that you don't think this patient's actually got something else going on as well, making your surgery less successful. So in conclusion, sarcoid is a multi-system disease. You have to have a high index of suspicion in otolaryngology in our field. Diagnosis is not purely histological, and the diagnosis can be challenging. We need an MDT care, and that's really dictated as by which organ systems are involved. Those are the teams that you can refer to. And treatment is really, in essence, it's based on severity of your systemic involvement and needs to be tailored as such. And that's the end of our presentation. Yeah.
Myself, yes, I have seen one here was presented as zoomed TB or lines, and only to review previous chest images, which were highlighted for the neuropathy, and then eventually we invoked pulmonology, and the diagnosis was made on okay. They found a lot of T cells.
There's a difficult diagnosis to make.
Yeah, so that's the only one I can see.
Yeah. Yeah, quite similar things. Okay. Which is that TB makes it difficult. I just because hernia, not green.
Oh, sorry. Hernia.
P-E-R-N-I.
Hernia. Thank you.
Hernia. Okay. Just straight.
Okay.
No, I think it's just important, as you said, to not write everything off to TB. Obviously, there are a lot of overlapping symptoms and radiological features.
Yeah.
Even it's like terms in terms of the sinonasal pathology.
Yeah.
I don't know if it's you rhinologists like to link everything to fruits, but sinonasal tuberculosis also has a red currant jelly appearance.
Yes.
Check in the literature, and they're talking about apple jelly and strawberries.
Yeah.
Your sentence by his hand up. Yours.
Yeah. Prof. Hiller? Yeah, just give me a second. Prof. Hiller, can you unmute yourself? Prof. Hiller, can you hear us? Let me just see if I can unmute this. Prof. Hiller, can you unmute yourself? Other people all unmuted. Prof. Hiller, I see you have your hand raised. Are you able to unmute yourself? Or perhaps you can type the comments in the comment bar. Let's see. Okay, let me see if I can help.
Stop your share.
Yeah, so everyone is unmuted. Sorry, hang on. Prof. Hiller, can you try and unmute yourself now? Sorry, can you try now? I've allowed everyone to unmute themselves. No, I can't unmute. Rauf, are you able? Maybe Rauf, you're on the chat. Are you able to unmute yourself? I just want to see if this is working.
Hey Louisa, I'm here and I can unmute
Eric,
myself.
are you able to unmute yourself? I can see that yours is not muted. I'm just checking to see if it's our problem or if it's a problem on the other side. There, Prof. Hiller, you unmuted.
Can you hear me?
Yes, you're very soft, Prof. Hiller, but we can hear you.
All right, let me just, okay, shout. Okay, guys, sorry about this. Okay, so I actually wanted to add a few things because of a case that I'm busy and Dr. Esti May are busy battling with. And Professor Fagan will have to bunk us out here at some stage. He actually knows about the case. We have a patient who has got vague symptoms, well, not very vague symptoms, bilateral major salivary glands with kind of sort of secretions that are coming out, and she's got paroxysmal bilateral swelling and pain. Can you hear me?
Yes, Prof, we can hear you.
Okay, so we actually have only got a radiological echo, which is sort of shows like kind of a milky cotton wool type changes in both parotid, but it's definitely clinical symptoms. And so if you look sort of ask the patients, in generally there's sometimes signs of fever or coughing, but there's no other clinical signs of TB. Now the problem is that, you know, the best, or any of the other diseases. The issue is that, yes, tissue is the best diagnosis. The problem is we can't really obtain each tissue, much easy tissue on the parotid, because we're scared to damage the facial nerve. So we have to resort, unfortunately, to an open biopsy, which is without risk, and actually get the right diagnosis. What I really would like to comment about is your non-histological diagnosis of sarcoidosis can actually sometimes be prompted by serum ACE elevated levels and also a lymphopenia. And these are the only two sort of criteria that have come up in my extensive research that can help you point to the diagnosis. Now, the serum ACE level is actually at the moment a point of discussion. Is a point of discussion because nobody really is, there's no consensus what really constitutes a serum ACE level. And we had ours measured twice by PET care, and definitely we're increasing over 1 year. But PET care still maintains nodes normals within limits. But whereas there are articles that now suggest that we have to revise those serum ACE levels to a lot more sensitive. We have to be more sensitive to it. That's number one. And number two is lymphopenia, a general lymphopenia in the patient, which is a little bit more accepted. But these are clinical diagnoses, and without a tissue diagnosis, it's very difficult to start treating somebody if you don't really have a tissue diagnosis. So I just wanted to alert you to the issue about the ACE level being not that easy to interpret and not that easy to apply, because there's at the moment no consensus at what it really constitutes elevated EC levels. And also, as I say, it can wane and wax with disease activity. And sometimes there may not be ACE levels, and yet the patient may have disease and vice versa. But it seems that if you have a patient with ACE levels, and that usually above 40 or 50 international units per liter, then you should actually really start investigating the possibility of sarcoidosis or any of these other chronic inflammatory diseases. I don't know if you came across something in your review.
Thanks for the comment, Prof. Hiller. I must say I didn't look into serum ACE to that kind of detail, but certainly something worth looking at. Yeah, I must say, I think that a lot of the time, from our perspective, these patients get managed very well by our internal medicine pulmonology partners. And, you know, they tend to lean towards requesting a lot more investigations with regards to blood work than we generally do, just from a resource perspective. So it certainly is worthwhile thinking about what you've said and maybe looking into it a bit more, rather than just being trigger happy and just requesting investigations which don't necessarily clinch a diagnosis.
Yeah, well, in this particular case, the patient only has got parotid manifestations, which is extremely rare, but it is reported. And the question is, we have tried trickle biopsies and we haven't got any diagnostic tissue because we tried to do it under sonar. So, because we're actually worried about damaging the facial nerve. And I'm not quite sure, Prof. Fagan, the case, I'm busy writing a letter of referral to you to help us out in getting a good tissue diagnosis. And what are your reservations about that?
The treatment is very, very unlikely to damage the facial nerve. It's in to the side, so I wouldn't be too concerned about that.
So would you be doing an open biopsy, and where?
Well, I have to see. You'd be guided by the imaging.
Hello.
You'd be guided by the imaging to try and hit the sweet spot.
Which is sort of heterogeneous.
Yeah. I think we'll have to see the patient and make a call.
Okay, but if you did an open biopsy of the parotid, where would you be concerned about damaging the facial nerve, or is that not really an issue?
It depends what part of the parotid you have to biopsy. If it's very superficial, probably not. You can work with the facial nerve monitor on. And if it's a deep biopsy, then you have to expose the facial nerve and be careful.
Okay, so you would not be adverse to doing such a thing, and if you had no imaging, where would you preferably do this? Because they're now also doing this for Sjogren's in Europe. They're also doing open biopsies of the parotid.
We would image it first just to see whether likely pathology is located.
Okay, so maybe we can report back to this meeting once we are being successful. But anyway, I just wanted to raise this issue about the difficulty in really clinching a diagnosis of a patient with very difficult symptoms, and sometimes it can only be limited to one organ or one or two organs. In this particular case, the salivary glands only. You know, so.
Any other questions or comments?
Thank you,
Sorry?
Prof. Hiller.
Yes.
Prof. Hagen was just saying thank you for your input. Are there any other questions or comments on the platform? I don't see any further questions. Thank you everyone for joining us this morning. Have a good day, and we'll see you again on Friday. We're going to end the meeting.